Hello there, I'm Kathleen Sterling. I'm a physician with Chesapeake Urology. I see patients in our offices in Montgomery County. My specialty area includes bladder health and urinary dysfunction. And I'm pleased today to be talking to you about a topic I'm very passionate about, which is the treatment of overactive bladder. We're going to be covering a few things, including what is overactive bladder and how to know if you have this condition. We'll then take a look at the many treatments that are available for treating overactive bladder these days. I imagine you're listening today because you or someone you care about is suffering from bothersome urinary symptoms. So I put a few statements up here, and I'd like you to think about whether any of these are true for you. Number one, I drink less before I go on a trip. Some people might feel like they cannot go on a car trip or even avoid travel altogether because they feel like they need to stop at the restroom every 30 minutes every hour, and they just can't travel comfortably. This next person is saying, I missed the best part of the show. You might have overactive bladder if you've noticed that you can't sit through a movie or a play without taking a break to use the restroom. I need a bathroom nearby. I worry I won't make it. It makes it very difficult to make plans, to do activities, to play sports when you have overactive bladder because you are concerned that you won't make it to the restroom if the urge hits. And this can really affect someone's quality of life. If you're going somewhere, you might feel like you need to identify the nearest bathroom just so that if the urge hits, you'll be able to find it before you have an accident. What I always want patients to know is you're not alone with your overactive bladder symptoms. This is a very common condition, and it's also a very treatable condition. I have patients who are women, who are men, who are 19 years old, and who are 90 years old, and everyone in between. It's estimated that 50 million people in the United States suffer from overactive bladder, and that an additional 20 million people suffer from fecal incontinence. Now, you might be surprised to learn that only half of those people with severe symptoms even seek treatment. This might be because they don't know what kind of specialist to turn to for advice on this very sensitive topic, or they're simply too embarrassed to talk about it with their doctors. I'm here to tell you that you're not alone, and there are treatments for overactive bladder. I think it's important for overactive bladder patients to understand how the normal bladder works and how their bladder may not be working in this manner. That can help set the stage for discussing what treatment options might be available and effective. The main symptom of overactive bladder is typically urinary frequency. What is urinary frequency? That's the sudden urge to urinate, and you might feel that this is difficult to suppress or even impossible to suppress. Some people have accidents while they're on their way to the restroom because they simply cannot suppress the urge to urinate. I do treat patients with other urinary conditions, including urinary retention, which means not being able to empty the bladder all the way. And one of the treatments we'll talk about can even help patients who have bowel issues, including fecal urgency, which means the urge to have a bowel movement that's difficult to suppress, as well as involuntary loss of stool, called fecal incontinence. A normal bladder fills slowly throughout the day. This depends on how much water a person is drinking. When the bladder fills, a normal bladder is able to accommodate the storage of urine, and gradually the person's desire to urinate increases, but they're typically able to suppress it. Once the bladder gets full, say 12 ounces or so, the urge might get stronger. However, a person with a normal bladder is able to make it to the restroom in time, and when the time is appropriate, to contract the bladder, relax the urethra and pelvic floor muscles, and empty the bladder at the appropriate time. In overactive bladder, this isn't the case. There is no gradual increase in the urge to urinate. The urge to urinate can hit very suddenly and out of nowhere sometimes. You could be lying in your bed getting ready to go to sleep at night and feel the sudden urge to urinate and simply can't go to sleep until you go to the restroom. You could be working at a computer at your office and have the urge hit. Sometimes people notice that they experience urinary urgency when they hear running water. For example, if they're preparing dinner in the kitchen and turn on the faucet to wash some vegetables, they need to use the bathroom suddenly and they can't go back to their task until they do so. There's a phenomenon called key in the door urgency, where a person gets to their house at the end of the day, and as they're putting their key in the lock, the sudden need to urinate overcomes them. And that can be very distressing. In addition to urinary urgency, often overactive bladder patients have urinary frequency. This means urinating 8 or more times in a day, which can be very disruptive. Urge incontinence is a symptom of overactive bladder as well, which means involuntary loss of urine or urine accidents, often requiring people to wear pads whenever they go out or sometimes 24 hours a day. A fourth symptom of overactive bladder is called nocturia, which means awakening 2 or more times each night to urinate. And that can cause you to be very tired the next day and make it difficult to stay awake if you're not getting a good night's sleep. What happens with overactive bladder? Overactive bladder symptoms typically occur because of an abnormal communication between the brain and the bladder. So this might lead you to feel an urgent need to urinate and cause your bladder to contract in an unwanted manner. And you might need to rush to the restroom and even leak or lose urine before you make it. Bowel function is something I'll just mention briefly since the main theme for today is overactive bladder, but just keep in mind that sometimes bladder and bowel issues do go together, and one of the treatments we'll discuss can help people with both bowel and bladder issues. The bowel issues that can be treated with this treatment modality include fecal urgency, which means the sudden urge to pass stool, fecal incontinence, meaning the inability to stop the urge to pass stool, and sometimes this can even occur without you even knowing that you're losing stool. So it goes without saying that overactive bladder can affect a person's quality of life in many different dimensions. This isn't limited to physical symptoms. This can affect your social life. It can cause people to alter travel plans or not want to go out to dinner with a friend or go to a movie. Sometimes people avoid intimacy because they're worried that they'll leak urine on themselves or on their partner during sex. Work productivity can be affected as well. We talked about nighttime urination causing people to be tired during the day. Additionally, you might be at work and you can't sit through a long meeting or complete a work project because you're having to get up to use the restroom every 30 minutes or every hour. This certainly can have an impact on your self-esteem and your self-image as well. People often have fear of accidents and have a loss of self-respect due to this condition, and it can be very embarrassing to feel that you're wearing pads all the time. It can be hard to feel clean. Sometimes the overactive bladder and urinary leakage can lead to skin conditions as well due to urine exposure to the skin. People have to change clothes when they go out. The list goes on, and these are just a few ways that overactive bladder can affect one's quality of life. I have a lot of patients who ask, is this condition a normal part of getting older? No, not really. While it is more prevalent as we get older, overactive bladder can affect young patients as well as older individuals. And certainly, even if it's a part of getting older, it doesn't mean it's something that you have to live with or that you have to accept. People ask, is this condition just part of being a woman? Certainly not, and it's treatable. The male patients might have the question, is this just an issue with the prostate? While certainly prostate issues and overactive bladder can coexist in a patient, and sometimes treating both can help the overall picture, overactive bladder is not just due to a prostate condition in many cases. Finally, I have patients ask often, is this caused by something I did? Was this my fault? Did I bring this upon myself? For example, if they were a teacher and they held their urine for long periods of time during a workday. The answer to that is no. You did not bring this on yourself. This is not a condition you could have prevented. Sometimes it's related to another medical condition that you might have, but in many cases, we don't know what caused the overactive bladder or caused any given person to have the symptoms. Overactive bladder, just like diabetes, just like high blood pressure, just like high cholesterol, is a medical condition and it's a disease, and there are treatments available for you if you have this. There's good news. There are treatments available to help you regain control of your bladder and bowel function. Some of these treatments are conservative treatments like lifestyle and fluid modifications. Others are small outpatient procedures that can have a long-term impact on your bladder and bowel symptoms. Your treatment options are going to depend a lot on how severe your symptoms are, and most importantly, what your treatment goals are. So at our first meeting about overactive bladder, we would spend a lot of time talking about what you hope to get out of treatment. We would do this together by following a patient care pathway. Keep in mind, this is not a one-size-fits-all approach. While some patients might respond to the first treatment that we try, other people might need to try several different options before we land on the treatment that's right for them. Additionally, many people benefit from layering multiple treatments or strategies in order to achieve a beneficial effect. At the initial consultation, we will discuss your symptoms. I also might have you keep a bladder diary of your symptoms, where for a 3-day period, you record everything you're drinking and every time you urinate, every time you have an accident, so we get a sense of what your baseline symptoms are. I would likely test your urine to make sure you don't have a urinary infection. Additionally, I may do a bladder scan, which is a painless, minimally invasive ultrasound on your lower abdomen to find out if you're emptying your bladder all the way. The initial treatments might consist of lifestyle changes, for example, adjusting the time and the type of fluids that you're consuming. People sometimes benefit from bladder training exercises, either on their own at home or by working with a pelvic floor physical therapist who can help them with their symptoms. And keep in mind, from time to time, we'll be reevaluating whether a given treatment regimen is working for you or not. What works today might not be what works for you 2 years from now, and there are lots of options on this pathway that we could offer. For people who don't respond to the initial treatments, there are advanced therapies, which I plan to discuss in detail with you today. Those include sacral neuromodulation, tibial nerve stimulation, also called PTNS, as well as Botox injections for the bladder. So to go into more detail about the behavioral modifications, these might be learning some urgency suppression techniques, such as relaxation of the pelvic floor or Kegel exercises. Sometimes people benefit from timed voiding, which means visiting the restroom every 1 to 2 hours, whether you feel like you need to go or not, and then slowly increasing that interval over time. People who get up at night to urinate might benefit from limiting their fluids after dinner time, so they won't have to wake up as many times during the night. Additionally, there are pelvic floor physical therapists who specialize in urinary dysfunction and bowel dysfunction, and they can help you with bowel training and bladder training using techniques like biofeedback. Sometimes avoiding bladder irritants like caffeine, spicy foods, and alcohol can help with your symptoms. And then there's medication. There are 2 basic categories of medication available for people out there. They both work on the bladder muscles by allowing them to accommodate to hold urine. Some people do quite well on these medications and can stay on them for many years with a good effect. In other people, they cause side effects that keep them from being able to take them long term. Percutaneous tibial nerve stimulation, or PTNS, is one of the advanced therapies. This is an office-based treatment. If a person chooses this therapy, they will come to the office for 30 minutes, once a week, for 12 weeks. We record your response every week and keep a journal of your response to therapy. You would do this by sitting in a comfortable chair. We put a small needle around the area of your ankle, sort of like an acupuncture needle, and attach a small device that delivers stimulation for the 30-minute session. Usually if people are going to respond to this, they'll notice a difference within the first 5 to 6 sessions. If you do well with the first 12 sessions, you typically come back once a month for maintenance. This usually is covered by insurance and works quite well for some patients, although it's not quite as effective as the other 2 options that I'll be discussing. The risks are low. People really have minimal side effects with this therapy. Sometimes people report a little bit of tingling or have bruising, but that's not typically the case. Another advanced option for treating overactive bladder is injection of Botox in the bladder. You may have heard of Botox treatments for migraine headaches, for muscle spasticity, and for other applications like cosmetic injections. This is the same medicine, it's just delivered directly into the bladder using a cystoscope, which is a small camera that goes into the bladder. This is usually done at an office-based procedure center. It's a very quick procedure. It takes about 5 minutes. Your bladder is numbed in advance with a numbing agent to help you to tolerate it better, and people generally do very well. It's got a very high success rate. People typically need to be retreated approximately every 6 months in order to sustain the beneficial effect. Some people come in every 3 months, other people come in once a year. We decide when to retreat based on when your symptoms start to return. This is very well tolerated. The side effect I like to tell people about is the possibility of having difficulty emptying your bladder after the injections. This is a temporary side effect, and it only affects about 5% of people. So there's a 95% chance that you won't have this problem. Another advanced therapy is sacral neuromodulation therapy. This is the therapy I mentioned that can help those with both bladder dysfunction and bowel dysfunction. So that includes overactive bladder, urinary retention, and fecal urgency and incontinence. One of my favorite things about this therapy is that you can do a trial of about 7 days to see if this is right for you in the long term. In order to do the trial, you come into the office-based procedure center. I put some numbing medication on your back and introduce a tiny wire into your upper buttock just above the tailbone. I then secure the wire with tape to your lower back and then attach it to an external clip-on battery. For that week, you'll keep a diary of your symptoms, and then we'll meet after 3 to 7 days to decide if you experienced an improvement in your symptoms, such that you can be advanced to the longer-term therapy. Specifically, what we're looking for is decrease in your frequency and urgency, less incontinence episodes for those of you who have incontinence. For those who have urinary retention, we're looking for a decreased number of times a person has to catheterize in a day. For people with fecal urgency, we're looking for fewer stool accidents and fewer episodes of bowel movements. If the trial is successful, then you can be a candidate for the longer-term therapy, which is a minor outpatient procedure. This is also done at an outpatient surgery center, and typically a patient will have some light sedation to keep them comfortable during the procedure. This is done through 2 tiny incisions in the upper buttock area, and for the long-term device, all of the wires are concealed, so that really you can do anything you want after the procedure once you've gone through the healing process, including swimming, exercise, or essentially any activity. The latest therapy on the market is called Axonix. This one is new to the marketplace. Its advantages are that the battery is a long-term battery and can last 15 years or more. Again, this therapy called Axonix can help those with overactive bladder, urinary retention, and fecal incontinence. The way it works is by modifying the signaling pathways between the bladder nerves and the bladder muscle in order to normalize urinary function or bowel function. How does it work? It provides gentle stimulation to the nerves that control the bladder. And the stimulation is gentle. It's not something that you feel as it's going on. It works in the background. As you can see, the battery is very small here in comparison to the size of a quarter. That's why it can be placed with 2 very small incisions. If somebody were to look at your backside, if you were in a 2-piece bathing suit or swim trunks at the beach a few months after the surgery, they probably wouldn't even notice that you'd had a procedure. Because of the small incision, the healing time is very short and people experience minimal discomfort or no discomfort after the procedure. And again, this battery is designed to last for at least 15 years. This new device to the market, Axonix, is MRI compatible. Previous versions were not safe to be used with MRI, so that limited a lot of patients from being able to get the therapy. So a patient with this version of the therapy is able to get a 3 Tesla MRI of the head and a 1.5 Tesla MRI of the body. So if you need regular MRIs for another medical condition, you are a candidate for this therapy, whereas with the previous generations, you might not have been. When you leave the procedure center, you'll be given this remote control. As you can see, it's very subtle. It doesn't look like a medical device. It looks like a car key fob. It fits in your pocket. It's very easy and discreet. Now, I'd like to point out that while this is very easy to operate with just a touch of a button, I wouldn't expect that you would be turning it up or turning it down or even using this remote control. It's just there when and if you need to use it, which for most patients is not very often. But it does give you the ability to make adjustments at home if you need to do so. This is a picture of the charging system for the device. Charging typically takes place once every 1 to 2 weeks for about 30 to 60 minutes. You can do this at your home while you're watching a show. You can do it at your office while you're sitting working on a computer. All you have to do is strap on this belt with a white charging puck and place the puck over your incision area. You'll get a gentle vibration that lets you know you're in the right place. And for 30 or 60 minutes, the device charges, you put the belt away, and then don't think about it again until next week. Almost all patients found that charging is easy after 1 year of therapy. 96% thought that the charging frequency and duration is acceptable, and most people are charging once a week or even less than that. This is a patient talking about the charging. She says, "Charging is as easy as anything. I can sit there and watch a program or read a book. And I carry my remote control on my keychain just in case I've ever needed to use it, but I've never had to use it. And that's true for most people who get the Axonix therapy. They have the remote if they need it, but usually don't need to use it. The Axonix therapy has been tested in clinical trials and shown to be safe and effective, and there's a high level of patient satisfaction. In fact, 89% of patients in the trial achieved clinically significant improvements in their incontinence symptoms when asked about these symptoms 1 year after the therapy. This is an amazing statistic and is not true for most other urinary incontinence and overactive bladder therapies. 1 year after their implant, over 90% of patients were satisfied with their results. Again, a very high level of success with this therapy. 93% were satisfied, 92% would undergo the therapy again with the same expected results. So it's remarkable if you think about all of these people achieving improvement in their symptoms, whether that's going to the bathroom less frequently so they can participate in activities that they want to do, having less urinary urgency that rules their life, perhaps going from using many pads a day down to using 1 pad a day or no pads per day, and having fewer stool accidents and less fecal urgency. This is a really impressive therapy. So now we'll hear from a patient who failed medical therapy, who failed conservative options, telling about her experience with the Axonix therapy and how it improved her symptoms.
I'm doing and what I'm drinking, and but then I got to the point where it was just interfering with everything. I felt like I had no control, and that's the point that kind of took me into a physician. At that point, I felt it would be, you know, a great thing just to try the stimulator. I mean, it was small. The surgery was it was minor. You know, it was same day, and I thought, well, if this can be more of a permanent solution, you know, not just something that I have to come in for every few months or a medication that I have to take for the rest of my life. The implant itself took, I don't know, less than 30 minutes. The procedure was quick. I remember waking up right away. It was within the clinic, the doctor's clinic, and I was home by lunchtime. Going into the implant, not really knowing what to expect, I'm happy that I chose it. I'm satisfied with the treatment. It's just great to have control. I guess it's hard to describe to someone that doesn't have the symptoms or have the issues, but when that kind of controls your life and when you feel like the inability to be able to do things or just be even in a store or to get home and have to, you know, compete with your family to get to the restroom and then now you don't, it's really comforting. It's great. It's absolutely great.
So I hope after watching this you feel that you're ready to take the next step and get relief of your overactive bladder symptoms. How to get started. If you haven't already done so, I welcome you to make an appointment to discuss your overactive bladder symptoms and to find out what treatment options might be right for you. My colleagues and I are currently seeing patients through virtual visits. That's telehealth, which can be a great way to connect with patients and talk to them about their symptoms and their treatments. Additionally, we're seeing patients in the office for those who prefer an in-person visit. Thank you. I hope to meet with some of you soon.
Thank you, Dr. Sterling. We would like to open it up for questions now. Dr. Sterling, our first question, is the interstim therapy available for older patients?
The InterStim therapy, as well as the Axonix therapy, which are both sacral neuromodulation therapies, are certainly available for patients of all ages who have urinary frequency, urgency, and leakage. If you're healthy enough to undergo a brief procedure under light sedation, which almost everyone is, then you'd be a candidate for the procedure potentially.
What is the overlap between IC and OAB?
That's a good question. So there are plenty of patients with overactive bladder. So that's the complex of frequency, urgency, and sometimes incontinence. And then for those who aren't familiar with IC, it's a chronic bladder pain condition. So interstitial cystitis, that's pain that lasts for weeks, months, years with no other explanation, whether that be infection or any sort of structural abnormality. I would say that most people who do have IC or bladder pain syndrome also have some of the symptoms of overactive bladder, frequency, urgency, and incontinence, whereas the opposite's not always true. Many overactive bladder patients do not have pain. So it's common for IC patients to have some overactive bladder symptoms, but overactive bladder is more prevalent, certainly, than IC. The treatments for overactive bladder and interstitial cystitis or IC sometimes overlap. The thing that they have in common is that neither are a one-size-fits-all type treatment and can often require a combination of different therapies to get control over the symptoms.
Are there new medications for OAB?
There aren't really any new medications that have come into the marketplace. There are two main categories of medication. There's the anticholinergic category, which includes about 5 or 6 different medications, both branded and generic medications. So all of those work in a similar manner on a certain type of receptor by blocking a signaling pathway to relax the bladder. And those are medications like oxybutynin, Vesicare, Toviaz, and several others. And then in a category by itself, there's Myrbetriq. So that involves activation of a different receptor in order to relax the bladder. And there's only one medication in that category. There aren't really any other new ones out these days. Myrbetriq is the newest, and that's been out a number of years, probably 8 years or so at this point, I would estimate.
Can you please talk a bit more about prescription medications and their side effects?
Yes, so the anticholinergic category of medications, the one with the several different medication options, are sometimes well tolerated, but it's fairly common for people to have side effects like dry mouth and constipation. Those are really the most common side effects that people experience. The anticholinergics, if they're going to work, they typically work within a few days or a week or two, and you also typically experience the side effects pretty quickly as well. So it doesn't take long to know if one of those medications is the right medication for you. The meds in that category are more similar than different. So usually if one of them is going to have a side effect, the others too. They have slight differences in the receptors that they activate, but in general, they're pretty similar to one another. The Myrbetriq tends to be a little bit better tolerated. So this one in some patients can cause problems with high blood pressure. Usually if you're someone who has a normal blood pressure to begin with, you're not going to have an issue. It's the people who already have poorly controlled blood pressure, if they're on multiple antihypertensive high blood pressure medications and those medications aren't working, I would be hesitant to offer the Myrbetriq medication to those individuals.
My urinary overactivity is particularly acute in the cold weather. Why would this happen?
I have a lot of people ask me that question, and I'm not sure of the scientific explanation for that. I wonder if it has to do with people's hydration patterns during cold weather. Maybe during hot weather, you're losing more through sweat or what we call insensible losses. So less of the urine is making it to your bladder. Whereas when you talk about being in cold weather and hydrating, more of that is actually going to stay in your bloodstream, get filtered through your kidney and go to your bladder. So that could account for some of the differences, but that's an interesting question.
Can you please talk a little bit about the electrical stimulation and the exercises?
The pelvic floor physical therapy is the most conservative way of approaching the overactive bladder, or one of the more conservative ways. That involves going for a series of visits to a pelvic floor physical therapist. So that's a therapist who's specifically trained to deal with women and men's voiding dysfunction or bowel dysfunction or issues of the pelvic floor. What to expect if you were to go to one of those visits. Often the first visit would include an examination and then a real detailed discussion of a person's goals. The therapist would identify what your strengths and weaknesses are and figure out a plan to take you through the next 6 weeks or so to allow you to achieve your goal. So you might tell them, well, my goal is to sit through a movie, and they would help you come up with ways to suppress your urinary urgency, possibly using techniques like biofeedback. Usually at the end of the first 6 sessions, they'll decide, are you ready to graduate and just do the exercises on your own at home? Or could you benefit from some additional therapy in the office? And this can be really helpful for some people.
Could you talk about some of the exercises that are helpful for OAB?
These are really specific to the individual person. Some of them might involve deep breathing exercises to suppress the urgency. So, for example, if you feel the urge coming on, you might close your eyes and take some deep breaths, count to 10, and see if that allows for a reset in order to let the urge go away. That could be one example. Another example might be doing quick flick Kegel exercises. So many of you have heard of Kegel exercises to strengthen the pelvic floor and to stop leaking from happening. With the quick flick version of it, instead of contracting the muscles of your pelvic floor and holding it, you might do a series of 10 quick repetitions. And again, that can kind of reset the circuit and make the urge that you felt go away. Those are just 2 examples. The pelvic floor physical therapist, though, will really customize the program to your goals, tailor it to your strengths and weaknesses to devise a plan for you. While we don't have therapists in our offices at Chesapeake Urology, I've got a list of good therapists in the area that I'm able to send patients to. And a lot of them have had good feedback and good results.
Could a urethral sling prevent one of the implants from taking place?
A person who has a urethral sling, which is a small piece of mesh that sits under the urethra and is usually done for stress incontinence, so that's leaking with coughing, sneezing, running, jumping, would absolutely not prevent someone from having any of the overactive bladder therapies. One would not interfere with the other. And it's actually fairly common for people to have both stress incontinence as well as overactive bladder or urge incontinence. So if you were to come to see me and tell me that you have both types of incontinence, we would figure out which of them is playing more of a role and having a greater impact on your quality of life, and probably address that one first, see what symptoms are left over, and then move on to the other type of incontinence. But someone who has a sling can get the Axonix implant, they can get Botox, they can get any other treatment for overactive bladder that any other person could.
Would Botox and the implant option decrease the occurrence of UTIs?
Botox would likely not decrease the risk of urinary infections. If somebody were having a lot of urinary infections, I might even suggest that we take a look at the sacral neuromodulation implant as a preferred option. That's for a couple of reasons. The Botox, as we talked about, can, in some people, a very small percentage of people, keep them from emptying their bladder all the way. It's a very small percentage, but if you're not emptying your bladder all the way, then you may be at increased risk for infection. The second reason is, with a history of urinary infections, putting a scope in the bladder and instrumenting the bladder directly every 6 months might put you at increased risk of infection around the time of the procedure. Now, I'm usually able to really minimize that risk by giving antibiotics at the time of the procedure, sometimes just one dose, sometimes for a couple of days afterwards. But I would say that in someone with recurrent UTIs, maybe I would favor the sacral neuromodulation implant because it doesn't involve putting an instrument in the bladder every few months. The sacral neuromodulation implant, or the Axonix, I would say wouldn't directly have an impact on your UTI risk. However, if you're a person who gets UTIs in part because you don't empty your bladder, the Axonix therapy does improve bladder emptying. So by allowing you to empty better, then maybe we would decrease your risk of UTIs in that manner.
How effective is the Botox injection?
The Botox injection has a high success rate. I would say it's about an 85 or 90% success rate, depending on how you define success. So whether that's decreased frequency, urgency, or number of incontinence episodes, on a lot of different measures, the Botox has a high success rate.
Why would OAB medications cause diarrhea? That has been my experience with the medication.
I'm not sure why in your particular case the OAB medications cause diarrhea. It could be one of the inactive ingredients in the pill that's causing the diarrhea. Although any medication can cause any side effect, especially when combined with a long list of other medications, we typically see, especially with the anticholinergic medications, that constipation is a much more prevalent side effect, not diarrhea. So I'm not able to explain that one.
Do a lot of people have hypertonic pelvic floors that cause the symptoms in the first place? Or does the pelvic floor tightness usually come on as a result of the bladder issues?
I think that the increased tone in the pelvic floor, overactive bladder, and any bowel conditions can't really be separated from one another entirely. I mean, the pelvic floor is a network of muscles, ligaments, nerves. The bowel, the bladder, the vagina are in such close proximity to one another that anything going on with one of those organs is going to affect the adjacent organs. So I don't know if it's really possible to say in any one person which comes first, but certainly there's a very intimate interaction between the different systems and the network of those muscles of the pelvic floor, the nerves of the pelvic floor. All of those conditions would probably benefit greatly from pelvic floor physical therapy, at least as one of the strategies used in managing their symptoms.
Can you please explain cystoscopy, and is that the procedure you use for Botox?
Cystoscopy is looking in the bladder with a little camera. So it's a minimally invasive procedure, and the scope is tiny and flexible. I don't know if any of you have ever had a catheter for a procedure or something in the hospital, but it's about the same size as a catheter and feels like a lot like a catheter going in. The only difference is I can see where the scope is going as I'm inserting it, so it's much gentler. I usually use some numbing gel on the end of the scope and in the urethra to allow for an easier insertion of the scope. And then once I'm in the bladder, I've got a view of the whole bladder lining, and patients often like to look on the monitor with me to see how their bladder looks. A cystoscopy by itself takes 2 to 3 minutes probably. It's a very brief procedure, no anesthesia needed. The Botox injection is a cystoscopy plus injection of some medication while I have the scope in the bladder. So while I'm in there looking around, I would also put the medicine in the bladder. And that's about a 5-minute procedure, I would say. For the Botox injection, in addition to the numbing gel, I have you come in a little bit early and get some numbing medication instilled through a catheter that allows your bladder to be a little desensitized to the installation of the medication.
Have patients had improvements by addressing vaginal atrophy with topical hormones?
I think that patients with atrophic vaginitis, which involves tissue changes that occur with a decreased estrogen state after menopause, can contribute to irritative voiding symptoms, including frequency and urgency. So I have seen people benefit from just application of a topical estrogen twice a week. sometimes that can solve the issue, or at least alleviate the issue. Usually when I start someone on estrogen, I make sure they don't have any history of breast cancer, ovarian cancer. If they have, I would want their oncologist's approval to start the estrogen. Typically, you would apply it once nightly for a week or 2 weeks, and then drop down to 2 or 3 times a week. But yes, I think that can be very helpful in improving the tissue quality of the vulvar vaginal area, and possibly provide some relief of the voiding symptoms as well.
Why does sexual activity increase the need to urinate?
Well, as we talked about, everything is close together in your pelvic area if you're a female. So if you think about everything that goes on there, you've got your vagina, and then you've got your bladder and your urethra right in front of it, and your rectum right behind it. So if you can imagine that sexual activity is causing inflammation or just irritating the vagina at all, it's going to have an effect on everything around it, including the bladder.
Are there any vitamins that can be taken to help with OAB?
I do not know of any vitamins that would be helpful in OAB.
There are 2 questions asking about the Mcella chair.
So I've heard of that, but don't have any personal experience with it. I know some of the offices in the community are using it. As I understood it, I think it's more for stress incontinence, but I am not certain about that. And that's not a therapy that I have any experience with.
Is there anything to be done about the failure to entirely empty the bladder when you have OAB?
2 things that might be going on if you think you're not emptying the bladder with overactive bladder. It could be the case that you feel like you're not emptying, but you actually are, and we can determine that with a bladder scan. Or it could be the case that you feel like you're not emptying and you truly are not emptying. So the first step would be to figure out which of those is the case. If you have overactive bladder and if you have overactive bladder and feel like you're not emptying, but you really are, that's just a typical OAB symptom. It's urgency, even though your bladder is not very full. So someone experiencing that could really benefit from any of the therapies that we mentioned: physical therapy, medication, Botox, neuromodulation. If it's the case that you actually are not emptying the bladder, meaning you empty the best you can, we do a bladder scan, and it turns out you're retaining urine, then really the main therapy that's going to work for you is the sacral neuromodulation, the Axonix therapy, because that's the only one that really addresses that problem. By applying the stimulation to the bladder nerves, we can normalize voiding function, not only reduce the frequency and urgency of overactive bladder, but also stimulate the bladder such that emptying is improved. So if you're somebody who has overactive bladder and truly doesn't empty, then you're going to want to try the sacral neuromodulation.
Are there any medical conditions that would prohibit me from receiving the Axonix treatment?
Are not really any medical conditions that I can think of that would keep you from having that therapy. It's now approved for MRIs of the head and the body, 3 Tesla. So that's pretty much any MRI that a person would need. So if you've got a medical condition that requires you to get MRIs frequently, that's no longer a barrier to the treatment. If you have a pacemaker, you can still get the device implanted. Those 2 things are the most common things I get questions about. If you are diabetic, then your infection risk may be a little bit higher, but that's true for any surgery. We give you antibiotics, which would typically minimize that risk. Same if you have some sort of immunocompromised state, we may give you extra antibiotics in that case to decrease your risk of infection. But really, anyone's a candidate.
Does being overweight add to stress incontinence and overactive bladder?
Definitely. There have been studies done that show an association between having a healthy body weight and improvement of symptoms of both overactive bladder and stress urinary incontinence. So to say that another way, if you're body weight is above the normal range and you were to lose weight, then you're probably going to see an improvement in your incontinence, both kinds of incontinence, stress incontinence and urge incontinence and overactive bladder. If you lose weight and you're still not happy with your symptoms, the upside is that you're going to go into a procedure a lot healthier, and it'll make your procedure and your recovery a lot easier too.
I think there might have been some confusion for several viewers thinking that a pelvic sling is a treatment for OAB. So can you just address the fact that that would not be the case?
So there's a type of incontinence called stress incontinence. So this means that you have leakage when you put stress, this is physical stress, on your pelvic floor. So if you jump, cough, run, sneeze, and you leak urine, this is called stress incontinence. The reason someone has stress incontinence is because their pelvic floor is weakened and is not able to brace against the flow of urine in the face of that stress. So, for example, if you've got a nice strong pelvic floor and your urethra is well supported, then when you cough or sneeze, the urine is going to have a speed bump, so to speak, as it exits your body and you won't leak. For people who have had, this is female patients in particular, who have had pregnancies, who have had hysterectomies, who have had chronic cough or constipation. For male patients who have had prostate removal or other pelvic surgery, their pelvic floor and the support structures might not be as strong. So we're able to restore some of that support by putting in a small strip of mesh under the urethra to increase the resistance and to support the urethra like a hammock. So that's a treatment for stress incontinence, the sling. Overactive bladder is more of an issue of the stability of the bladder. So not the support at the bladder outlet, but the bladder itself being hypercontractile, being inappropriately stimulated to squeeze, to contract when the bladder is not even full. So the treatments for that would be quite different. The physical therapy, the medication, and then the procedures addressed at stabilizing the bladder and normalizing communication between the bladder nerves and the bladder muscle.
Does Medicare pay for the Axonix therapy?
Medicare and most other insurances do typically cover all the treatments that I've talked about. Now, for some of the advanced therapies like the Axonix or for the Botox, some insurances require you to try one of the more conservative options first. That's not always the case, but sometimes it is. But usually it's not an issue to have this procedure covered by insurance. We have a department at Chesapeake Urology. If someone's interested in the procedure, we actually do the homework and make sure that it's covered before we bring them in for the procedure, and typically find that it's not an issue. It does depend on any one individual plan and your copays, of course, but it's typically covered in part, at least by your insurance.
Nocturia is the biggest problem, and this patient is taking a prescribed medication but is not helping. She wants to take the next step but be conservative. What would that next step be?
I would take a close look at what you're drinking during the daytime hours and at nighttime. I usually recommend people stop their fluids 3 hours before bedtime. Sometimes it can be helpful to elevate your legs above the level of the heart a couple hours before bedtime. As we get older, the body tends to mobilize fluid more in the evening time as compared to the daytime. So if you're able to get your body to move the fluid off before you go to bed, before your head hits the pillow, then sometimes that can be helpful. I'd also take a look at caffeine consumption. Even if you're consuming caffeine early in the day, sometimes that can stay on board longer than people realize and possibly be a diuretic or stimulate the bladder through the night. So those are some real conservative things that someone could take a look at and try to optimize before moving on to any sort of other therapy.
Can you talk about how long Botox and the Axonix therapies have been around?
The Botox therapy for overactive bladder has been FDA approved for 10 years or even more. It's a safe and effective treatment and has been around for a while. It's used for a lot of other applications and is approved for that as well, and is shown to be safe in many different applications and across different specialties. The Axonix therapy is new to the marketplace under the name Axonix, and with the current technology that's MRI compatible, rechargeable. All of these are brand new developments that everyone's very excited about. The concept of sacral neuromodulation, though, in its essence, has been around for 15, 20 years. So the Axonix device itself and the improvements are new and exciting, but the therapy as a concept has been around for many years and is a safe and effective option.
Do you know of any studies going on for new medications or supplements such as pumpkin seed extract?
I do not know of any trials going on for medications or for herbal supplements for overactive bladder. I just want to thank everyone for joining us tonight, and I hope we've answered some questions that you all have. If you have questions that are more specific to your case or want to talk about any options that might be right for you, then come see me and we'll chat about your symptoms and about the therapies that are available to you.
Okay, one last question. Is vesicoureteral reflux a risk factor for OAB?
Vesicoureteral reflux is for those who don't know, is a condition that a person's typically born with, where the bladder refluxes or sends urine back up to the kidneys due to a malfunctioning valve system. Although that's not a risk factor directly for overactive bladder, some people who are born with that condition might have issues with bladder capacity, or maybe have had past surgeries to correct the reflux such that their bladder may not be as accommodating as the average bladder. So some of those people may have overactive bladder symptoms, but the treatment of the reflux wouldn't necessarily fix the overactive bladder or vice versa.
Okay, thank you, Dr. Sterling. Thank you again, everyone, for joining us and for your great questions. Chesapeake Urology's 26 statewide offices are open for input patient appointments and telehealth appointments. Please visit ChesapeakeUrology.com for more information, to have more of your questions answered, or to schedule an in-person or telehealth appointment. Thank you and have a good evening.